Good morning. I'm Dr. Sean Coomer, Chief Medical Officer at the University of Kansas Health System, Kansas City Division. Welcome to Open Mics. We all know cancer screenings are vital to survival. Early detection is key, but what screening should we do when you're my age or older? That's our topic today. Joining us today in studio is Dr. Nina Mathew, a clinical oncologist at the University of Kansas Cancer Center. Also joining us is Dr. Jessica Kalender-Rich, a geriatric medicine specialist at the University of Kansas Health System, and Dr. Kalender-Rich's mother, Phyllis, is also here with us. Thank you all for being here. Dr. Kalender-Rich, let's start with a big picture. When we say cancer screening for older adults, are you talking my age or older? And who are we talking to?
Yeah, it's a really good question. I think it's a big body of discussion that happens, right? And so as we think about screening for cancer is a goal of finding things early so that we can do something about it before it becomes a big problem. So when we also, cancer treatments have other risks and other pieces that are part of the puzzle. And so it's not about age necessarily. Maybe it's about age as we start screening and about risk factors that also exist, but it's not really about age so much when we stop screening. It's really about the whole person. What would they do if we found something? What could they do based on their other medical risk factors or functional risk factors? What would they want to do, right? And all of that comes into the puzzle of, gosh, you are 70 years old, does it make sense to do this screening? Or maybe it only makes sense to do a different one because that's the disease that we could find earliest and treat most easily.
And it also has to do with that biological age thing we talk about, right? And what makes sense for that individual. It's tailoring the medicine to the individual, right?
Right, so biological age versus chronological age,
yep.
Right? And we can, chronological age, and we can really only know someone's chronological age unless we've done a really deep dive into their biological markers.
Gotcha. Yeah. So what have you recommended for your mom?
I mean, she is very healthy and really everything. Right. So when I think about some of the sort of time to where these cancer screenings become less helpful, right? If you expect someone to live more than 5 or 10 years based on their other risk factors, really that's the person that should get all the screenings. That's the person should continue having colonoscopies and mammograms and bone density scans and all of, well, that's not cancer, but obviously, but all of the screenings that really would identify something early. So you get the full gamut.
So Phyllis, first of all, thanks for being here and
Sure.
sharing. It's so much more impactful when we have a patient going through that and telling their experiences. So can you tell us what tests you have done for screening?
I sure can. I go to a dermatologist once a year and have my whole body checked for cancer spots. Or if I see something after I've been in the sun too long or something and I see something unusual, then I definitely go back. I do colonoscopies. I will tell you that after 75, they say you don't need any more. So I haven't done it for a while. I've done mammograms every year religiously. I have had the bone density test, but that's like neither here nor there. But yeah, I do everything I can. Or she yells at me. So yes.
That's okay, but she cares about you, that's
I know,
why.
right, exactly.
So sometimes a gift, sometimes a curse, where you're telling me I have a physician
definitely.
As a child.
Yes,
I understand.
Definitely.
So for men, we all need to get a prostate cancer screening. Lung cancer screenings are important for past or current smokers. But Dr. Mathew, what other considerations should factor into screening decisions for seniors?
Yeah, so one of the biggest things that we think about is how screening is not a one-size-fits-all thing, right? Especially for our older adults. And so we look at someone's overall health, their functional status, their other medical conditions, life expectancy, et cetera. And so just like Dr. Kalender-Rich was talking, in geriatric oncology, which is cancer care in older adults, one of the key principles is distinguishing this difference between someone's chronological age and then their physiologic age. And so you can have two 75-year-olds sitting in front of you, but one may be extremely active and running marathons, whereas the other may be medically very frail. So how you approach them when it comes to cancer screening will be very different. We also take into consideration whether a patient's going to realistically benefit from finding a cancer early. Are they going to be able, are they healthy enough to undergo treatment if you find that cancer early? Because cancer screening is only helpful if it's likely to meaningfully change outcomes for that patient. And then also I would say that age is still the #1 risk factor for cancer in general. So having these conversations becomes increasingly important as we get older.
So what are some of the most common misconceptions among seniors when you start talking cancer screenings?
Yeah, I hear a few things in clinic. Some patients will say, I feel fine, I don't need screening, right? But I mean, I think screening is really meant for the patients that feel healthy, right? I mean, the goal of screening is to detect cancers before someone has symptoms. And you know, in a stage where it is highly treatable and curable. I have other patients that'll say, oh, hey doc, at my age, if I do have cancer, I wouldn't want treatment anyway, which I think is very valid. I always want my patients to understand that cancer treatment today is much different than what it was even 5, 10, 15 years ago. Many cancers that are found early are very treatable, very curable, often with less intensive treatments than people might expect. And then finally, I think some people kind of automatically assume that cancer screenings stop at a certain age, but just like we've been saying, that that decision should really be individualized.
Yeah, I think you made some great points there. I think when people hear the cancer, the C word, whatever people say, they assume, and you know, obviously it's you know, relayed back to some historical thing, a family member or a friend that went through it. But every cancer treatment for every different cancer is different and tolerated differently, and even the same treatments for the same cancer can be very individually different. So
Exactly.
yeah. So here's what some of you in the community had to say about cancer screenings for seniors.
If I could get screened every day by a dermatologist, I would. Colonoscopies, the prep is not that bad. Just go ahead and do it if you're of the age, and it's just not that hard. But the alternative is very hard not catching it.
I used to have a mammogram, but my doctor said after 80, I don't need to do it.
Okay. What about, did he ever say what about colonoscopy? You know?
I used to have it done until a couple years ago, but I did it regularly. I did take a colonoscopy test.
I did my colonoscopy and they found polyps, so they got rid of that. So now I don't have to worry about getting a colonoscopy again for, I think, for another 2 more years. Past 3 years.
It's not just for older people, so it's okay to get screened whenever, but no one really thinks about that because it's just something you think about with old age.
Early detection is the best way, so I think everybody should have more testing done.
So I think it's good to probably just get checked for all of them, because I know my Mima always gets checked for skin cancer before she goes to Florida, and when she comes back, it's just like a safety because of the UV, so I know that's really serious, but probably breast cancer for women specifically.
I'm 71 and I kind of feel like I'm past, you know, I used to get mammograms every year, and then there was just a point where I decided I'm not going to do that anymore.
From what I understand, a lot of cancers are coming up early now these days.
Well, they should do mammogram for men also, because men could also have breast cancer.
Dr. Mathew, you just heard a range of perspectives from people wanting more screening to others stopping altogether. What do you say to patients about why some screenings stop at a certain age and others have a clear upper limit?
Yeah. So this really comes down to whether the potential benefits of screening will outweigh any potential downsides. So as we get older, screening tests can sometimes lead to what we call overdiagnosis, which is finding cancers that otherwise may not have caused any harm during someone's lifetime. Screening tests themselves can carry risks, especially invasive procedures. So if different organizations or guidelines have that upper age limit, it's usually because there's evidence that the risks may begin to outweigh the benefits for the average person at that age. But guidelines are just that. They are meant to guide, so they're not absolute rules, right? So that's where still having that discussion with your physician is really important. A very healthy older adult may certainly be fine to continue cancer screening, whereas for someone else, stopping screening might actually be the more appropriate or thoughtful decision.
Thank you. Dr. Kalender-Rich, how often are you having these exact conversations in clinic, and what would you add to that?
Yeah, I mean, we are having these conversations all the time, right? Particularly in the clinic, but also I see patients in assisted living and in other settings of care. We're really having these conversations because everybody is different, you know, to what Dr. Mathews was saying. Everybody is different, and we have to really individualize what decisions we're making, and they have to be a part of that, right? So their goals really drive their plan, which means if their goal is to live as long as they can and to do all of the things that might entail, and they're medically likely to be capable to do it, then we want to pursue, right, any kind of screening. But to the person in the video who said, I'm not doing mammograms anymore, I'm 71, right, my question for her is, you know, kind of, but why, right? What is it that you're afraid of? You know, would you want something treated if they found it? And if the answer is yes, then we need to be looking for it early and not waiting for there to be a catastrophic situation.
Yeah, it is interesting because some people, you get to the point like, well, if you're not going to do anything about it, then maybe you shouldn't do the test, the screening, right? That's what it comes down to.
But if you're going to do something about it, then we should be doing the screening test.
Absolutely. Phyllis, for you, how important is peace of mind when it comes to screenings?
Very important. I mean, I want to live my life actively, and I don't want to not do something about it if something is wrong, because I would do something about it, absolutely. It just depends on, like you said, everything is different. I'm healthy now. My parents have lived a long time, so I feel like that's very important to me. And I have amazing grandchildren and children. So yeah, it's very important to me.
Yeah, absolutely. You know, and with age and time, obviously, getting an operation, let's say, or chemotherapy at a younger age, or even 2-5 years from now, is very different.
Right.
Not just the treatment, but obviously what your body can take.
Exactly.
So earlier is better, that's for sure. So MCED tests, which stands for blood-based and multi-cancer early detection tests, show promising performance in adults 50 years and older, and are approaching FDA review that will consider all the things we've discussed, from mortality benefit, overdiagnosis, and who truly benefits. I believe our approach to personalized medicine will continue to also guide us as we are able to treat each person with their own unique bodies and health risks as individuals. Dr. Kalender-Rich, as screenings become less invasive, like a blood test, how will your advice on risk versus reward change?
You know, I think as the screenings become less invasive, there are fewer barriers to having screenings done, and that's great, right? Because even thinking about the colonoscopy prep, that is perhaps the thing that many folks dread the most out of all of their screenings. On the other hand, we need to know that any options for treatment are things that would be able to be handled by that person, right? And as treatments become less, I don't want to say toxic, but easier, right? Easier on the body, easier to handle, still difficult, but easier. There is more opportunity for us to screen easier and treat easier, which really just broadens our ability to prevent and treat early disease.
So we recently shared how the Masonic Cancer Alliance funded a mobile cancer screening bus designed with folks living in rural areas in mind in particular. It is just now literally rolling out. Dr. Mathew, how, if at all, do the conversations change when a patient lives in a rural area?
Yeah, I mean, I think access becomes a huge part of that conversation. You know, access to cancer screenings, it shouldn't depend on your zip code where you live, right? But unfortunately, many patients in rural communities, I mean, they may have to travel hours in order to get a colonoscopy or a mammogram, to get a CT scan, or to see a specialist. And then this can create real barriers, whether it's transportation, gas prices nowadays, you know, time off work, caregiver support, things like that. And so at the end of the day, though, patients that live in these rural communities, they deserve guideline recommended care just as much as anybody else. And so that's why I think initiatives like this mobile cancer screening bus is really exciting, because you're bringing those preventive services directly to the communities that otherwise might have limited access. And I got to actually see the bus in action at a recent 5K. That was sponsored by the Outpacing Melanoma Foundation. They were doing free skin cancer screenings for the community, which was wonderful. So community outreach and improving access, I mean, I really do believe that it saves lives.
Yeah, I think one of the biggest tenets of rural health transformation and the Patterson grant that's been received is about improving rural health and care close to home. So this is one effort to do that. So it's fantastic. What do you think of these mail-in cancer screenings, which we see on TV all the time, like the ones they do for colon cancer screening?
Yeah, I mean, I actually think that they can be a good option, especially for your average risk patients that otherwise might be avoiding screening, like Dr. Kalender-Rich mentioned, like they might not want to have a colonoscopy. And so specifically for colon cancer, these tests are often looking for the presence of blood or maybe abnormal DNA markers that are associated with cancer. These tests are convenient, they're non-invasive, so it increases participation in terms of screening. They're not a perfect replacement for colonoscopy, right? A colonoscopy is able to prevent cancer because you're able to find and remove precancerous polyps, which a stool test just can't do. And I think the other thing to remember is for these mail-in tests, if they come back abnormal, the next step is still going to be a colonoscopy.
Yep. Yep. Great points. Thank you. Dr. Kalender-Rich, where do you draw the line on colonoscopy screening? When does the benefit no longer outweigh the risk?
My line is very wiggly. Right? Because the time to benefit for colonoscopy is really in this like 8 to 10 year range. And so my line is really based on what's happening with somebody medically, right, and functionally. And there are lots of tools out there. Doctors are really good at a lot of things. We are not so good at prognosis and life expectancy estimation. So there are some calculators out there that I think we can and should be using more often to think about really putting in our patients' data and thinking through, okay, so this might benefit them. And frankly, sometimes I'm surprised that something really would benefit a patient, and sometimes I'm surprised the other way. And so that makes my line very wiggly, but it also means that it really involves shared decision making between us and the patient and whomever is with the patient to really ensure we have a really solid picture of what normal actually looks like for them.
Yeah, I think we're starting to use a bit of those predictive analytics currently here at the health system. I know for surgery, a lot of people do that, whether people can benefit from surgery or potentially decrease your quality of life. So those are very good tools out there. But Phyllis, can you tell us, when was your last colonoscopy? And are there certain screenings you anticipate not continuing forward?
So my last one was probably 6 years ago, and I'm not planning on continuing that because I have had very good if you can call it a good colonoscopy. I've had good ones, so I feel like I'm safe, and like you said, it outweighs the age limit and everything. So no, I probably won't have any more, but I've had quite a few.
No. Right. Well, thank you for sharing that. So we're here to answer your questions. Please send them in using the links on your screen, YouTube, Facebook, or email the Medical News Network. Let's check in with Doc Hawk. Dr. Hawkinson, KDHE announced in coordination with the Centers for Disease Control and Prevention and a local health department, 3 people with a high-risk exposure to a person with confirmed Andes hantavirus are being monitored. KDHE hasn't said where the individuals are from. They were not aboard the cruise ship and are not currently experiencing symptoms. Doc Hawk, does this change things for us locally? Where's the risk factor for people here?
Yeah, great question. I'm getting those questions on text and when I see people all the time about hantavirus now. Again, right now locally, for the vast majority, really everybody right now, there is no danger. There is nothing anybody should worry about for hantavirus itself. Again, I would say you're probably more at risk at picking up a common cold right now or tick bite or tick-borne disease or something like that. But right now, yes, very general information from KDHE from yesterday. Again, really no danger. National experts, world experts continue to say that overall this remains very low risk to the general population. And if you remember, this is not a new disease. This is not something like SARS-CoV-2. This virus, this entity has been known for 30 years or more. There have been outbreaks before, particularly in Chile and in Argentina. So this is nothing new. As long as we can all continue to do the appropriate things such as monitoring, like it seems like they are doing now based on the KDHE report, and other contact tracing for cases or suspected patients or contacts around the world, this should not get out of hand. I don't think anybody is expecting this to become a large outbreak such as SARS-CoV-2, which we have all gotten through and are still having trauma from that as well. But just to kind of settle everybody down, there's not danger to the general public.
So we've all learned a lot about this virus in the past few weeks, with the cruise ship and so forth, and people going to Omaha and Atlanta for isolation. But we keep hearing that you need prolonged exposure. What does that mean?
Yeah, I mean, in general, and again, we're speaking about generalities now, not nuances, but we know medicine and science, there are nuances and caveats and details. But in general, you do need that close exposure. And again, here we have just a electron micrograph of the virus on the screen right now. But you need, typically, we are talking about within 6 feet, prolonged exposure, meaning 15 minutes or more, things of that nature. It is quite different than, say, measles, where if you are in that space with that person and they have it, or you come into that space 2 hours later, you can still get infected with that virus, or even SARS-CoV-2. Even for when they did a prospective study in Chile over several years looking at the different cases, even what they found that in the household contacts, there was only about a 1.2% attack rate. And now if you compare that to measles or say SARS-CoV-2, where you have nearly 80, 90%, 100% attack rate of in-home contacts, it is quite different and quite a bit more difficult to get this infection compared to some of those other infections.
So we know there's a plan for patients who may have been exposed or need treatment. First of all, can you tell us a little bit, what's the incubation period? What are the symptoms?
Yeah.
How do you treat folks, and where do the patients go and why?
Yeah, well, I think you asked a great question, incubation period. Again, for most cough and cold viruses, we're looking at 2 days, 3 days, 4 days to develop symptoms. Unfortunately, for this type of infection, you could be waiting up to 42 days to develop infection or symptoms. The vast majority seem to have symptoms starting around that 2-week period. So there is a quite long, extended incubation period where you may not have symptoms. That does make contact tracing a little bit more difficult. But again, most people that are spreading the disease do have symptoms. It is not like SARS-CoV-2. There's no evidence that says that you are passing the disease when you are asymptomatic. Symptoms include a prodrome, so initial symptoms such as fevers, chills, a lot of abdominal pain you can have as well, things of that nature. You can then develop cough, shortness of breath, trouble breathing. That can then occur several days later, and that is really what we are talking about when we mostly talk about hantavirus, is hantavirus pulmonary syndrome, where you can get respiratory failure, you need to go on the ventilator, you need help with your breathing, things of that nature. About 50% of the people can progress to that type of severe infection. And again, unfortunately, there is about a 30 to 40% mortality rate. But again, that is also in different countries. We certainly have different mechanisms of supportive care here. Most of the care is supportive. There is no active antiviral medicine to give for this. So we just kind of support you with your breathing, your blood pressure, things like that.
So we all know that patients should call ahead to the emergency department and their doctor's office when they have this prodrome or anything like that, because we don't want to infect people in the waiting room, right? So really want you to drive that point home and kind of talk to our audience about that, if you would.
Yeah, I think that's anytime you're sick, and especially if we're talking about, let's focus on measles. That is vitally important because it can be just spread in the air, and that virus can stay in that clinic waiting room or wherever you may be for another 2 hours. So that is vitally important for that. It's also vitally important for this, but I do want to again point out that unless you've had contact with a known case of hantavirus, if you are feeling sick or ill right now, 99.999% of the time or more, this is going to be something different. We want to just kind of put your mind and your heart at ease. Again, really no general danger for the population here at this point in time. But yeah, if you are sick or something like that, or any illness, in the wintertime, if you have influenza or a cough, going to a clinic visit, you may want to wear a mask. You can always call ahead to see if they want any special things. But in general, for this infection, for hantavirus, Andes virus infection, again, no general danger to the population.
So again, let's remind folks out there, best way to stay safe, the pillars of infection prevention, and how do they apply to hantavirus or not?
They absolutely do. So again, if you're sick, please don't go out. You just mentioned one thing you can do if you do need to go to a doctor for evaluation, maybe call that clinic ahead of time. The other things to do is understand those situations, those environments that you're in. Hand hygiene always remains important. You may not be within that 6 feet of space or less in a patient, but obviously if a patient is sick with whatever disease they may have, they could be coughing, sneezing. Those viral particles then fall onto the high-touch surfaces such as tables, railings, door handles. And as you're touching those and then touching your eyes, your nose, or your mouth, you can infect yourself that way. So adequate hand hygiene is vitally important with soap and water or alcohol hand sanitizer, and then really trying to avoid touching your hands to your face, such as your eyes, your nose, your mouth. All of those things will help keep you safe.
Thanks, Dr. Harkinson.
Yeah.
We know many of you have questions, so let's head to Studio B with Jess.
Hey, good morning, Dr. Coomer. Jeremy has a question. He says, are there health issues or health histories that make you more likely that you should get the screenings versus maybe an age cutoff? Like if you take 10 people who are over 75, maybe only, a few of those 10 would be helped by those screenings.
Want to take that?
Sure. Yeah, I think, looking at someone's personal medical history and then their family history as well can play a role when it comes to cancer screening. If you have a stronger family history for certain cancers, then the necessity for those cancer screenings goes up. A lot of it, when it comes to cancer screening, though, is very generalized for the population, and so kind of using the age cutoffs are kind of just guidelines that different organizations have put out there for us to look at.
We have one more question, Dr. Coomer. Jill wants to know, what questions specifically do patients need to ask before accepting or declining a cancer screening?
What are you going to do with it? Right? Like we should all, anytime our physician is recommending anything, right? The question back can always be, and then what? Right? So I'm prescribing a screening for you, and you should get to know what you're going to do with it. What and not in details, right? I can never know like what that colonoscopy is going to show, what that mammogram is going to show. But if it shows something, my plan is we're going to send you out for treatment, or we're going to think through something else, or like what options exist out there in big, broad strokes, I think are really important. And then the other question that's really good to ask is, what are the risks of that screening test? So the risks might be needing to have a secondary test, right? You have a mammogram, and then if they find something, then there's a secondary test to really confirm something or identify whether something is there. And so just really thinking ahead beyond let's schedule this, to, okay, but what happens if you do find something? Which, by the way, opens the door to, but I would never get that treatment. I would never do that, right? Which, maybe that means you rethink the whole plan in general. So yeah, the why.
Great, thank you. So this has been a great discussion. I'm grateful to our guests for being here. And I want to get everybody's final thoughts before we go. Dr. Kalender-Rich?
Talk, like everyone should talk, right? Think about the repercussions, think about the opportunities, and then really drill down into individualized patient decisions based on what you want as a patient, what your physician thinks is the most reasonable option, and really just think about, gosh, we are all here to live better, not always longer, and how do we make that happen?
Okay. Phyllis?
I think the quality, like Jessica said, the quality of life is very important to me. So if, God forbid, I would have something, you know, I would figure out what am I going to do next. But the quality of life is more important to me.
Dr. Mathew?
Yeah, I think my biggest takeaway from today's discussion, and we've said it several times, is that cancer screening should be individualized. Having these discussions with your doctor is really important. The goal is early detection, trying to find these cancers when they're most treatable and curable. But these screening decisions should also reflect a patient's overall health, their goals, their preferences. We want our patients to be informed and empowered and involved in these decisions. And so overall, really wanting to step away from treating age as a number and focusing on the whole patient.
Great advice. Jess, what's coming up tomorrow on All Things Heart?
Well, tomorrow at 8 a.m., a routine physical uncovers a life-threatening heart condition. A 40-year-old, he never saw it coming. How one nurse practitioner's good ears led to open heart surgery and a remarkable recovery just 5 weeks later. That's coming up tomorrow on All Things Heart.
All right, thank you. Thanks again to all of our guests and to our audience. Remember, faith, hope, and science.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.